Good morning. Thanks to everyone for braving tube strikes and threats of downpours and making it here today. I think we've got a few people who've been delayed by train problems separate to the tube strike and will be sort of joining us. But thanks for joining us for what promises to be an extremely interesting morning on the power of collaboration. We've got some great speakers who Paul will be introducing in a second. I just wanted to say a couple of remarks about how the development of the CCIO movement has really kind of reached, I think, a kind of critical mass by the beginning of this year. we recently published the CCIO Vision and 12-Point Plan, which was developed by the CCIO Leaders Network Advisory Panel. That's had a very good response from government. We've had a request for a meeting with ministers. The chairman of the CCIO Leaders Network, Joe McDonald, is hopefully going to be having that shortly. We think that in terms of the numbers of CCIOs and people with equivalent roles out there in the English NHS alone, that there's now about 60 people in post. And that's, I think, remarkable progress over the last couple of years. The fact that so many of you in this room are CCIOs, or are doctors, or nurses, or other clinicians, has been pointed out to me by Dr. Fordry that very rarely do you have meetings about health IT where doctors outnumber the salesmen in the room. So I think that's worth acknowledgement. Having said that, I would like to give special thanks to our sponsors, without whom these events aren't possible. And CSC were generous in their support for the CCIO Leaders Network, and we hope that's going to continue. And without some further ado, I'd like to hand over to Paul Shannon, who's been asked at rather short notice to take on the chairing of this morning. Thank you, Paul.
So I've got a statement for you.
No, sorry, on the laptop.
Oh, this one?
Yeah.
So that's the title of today. Thanks, John. What do you think of this statement? First question, when do you think that was stated? 2000? 79? 1997, the Department of Health said that. So that's 17 years ago. Department of Health, do you think it's still true? So that, what I think would be quite useful, just keep that statement in mind as we go through the day. I remember reading that as a registrar and thinking, yeah, absolutely, this is what we need to do. So now, as a long in the tooth consultant, anaesthetist, I think, yeah, we're nearly, we're on the threshold of that. So my name's Paul Shannon. I'm the medical director of CSC in the UK. But I also am a consultant anaesthetist in Doncaster Oxford, so I feel I've still got skin in the game, as it were, with that IT system. And the purpose of today really is to, we feel that we've already made an argument of why you need CCIOs. So the question is now, how do we actually make that happen in reality? By the end of today, what I hope is that you will have been exposed to some good examples of good practice, that you will have some ideas to take back to the ranch, and the most important probably is that you will have met like-minded people and be part of what something you could call a community of practice. This is a relatively new thing in the UK, and so you in the room, are the people that are hopefully going to make that statement a reality. Because that's one of the differences. We didn't have this kind of group in 1997, but we do now. So I'm going to hand over straight away to our first speaker, Colin Brown, who's a gastroenterologist in Morecambe Bay and CCIO there. and I'll let him introduce himself a little bit more and kick us off into the first session. What I might just say is, from the point of view of the day, today we will have 4 speakers who are all going to shorten their talks a little bit to give us some time for questions and answers at the end before refreshments. And you'll notice this bit about table discussions. That's the sort of interactive, interesting bit. We've got some questions for you to think about. There'll be 2 questions, and you can choose which question you want to be in, or it might be just where you happen to be sitting. It does require that you kind of enter into the spirit of the interaction. So I am expecting a lot of creativity, and we must be surely a creative group in this room. So I'm hoping that everybody will enter into the spirit of that, and there'll be a short feedback session at the end.
So I've recently read a book by Jeremy Vine that I found very interesting, and he in that book outlined 1 or 2 rules of life, and the Financial Times apparently have a rule whereby if your job title is more than 2 words long, you are not important. And therefore, by way of introduction, I'm Colin Brown, Chief Clinical Information Officer of the University Hospitals at Morecambe Bay NHS Foundation Trust. There we go. So let's move on to someone who is important. And for me, this slide encapsulates the complexity of care in the NHS in the 21st century. It's faster, it's more furious, it's multidisciplinary, involves multiple departments, hospitals, organisations. It's really complex. And for me, the support of the paper record is well passé. We need to move on. And of all the people in this slide, the one that counts is the patient. So that's what it's all about. And in thinking about talking about leadership through a systems implementation, one can regard it as an event, a go-live event, or one can regard it as more of a long-term evolutionary process. And of course, it really is the latter, and that's the focus that I've chosen for today. It's a process, it's long, it's over time. And what I'm going to do is just briefly describe our journey in Morecambe Bay. I'll explain our long-standing strategy towards developing a single electronic patient record which spans hospital and community, and for us we're using Alonzo as the core components of that at the hospital side. I'll talk about some of our interoperability and portal capability in Morecambe Bay, but also focus on the leadership that's needed and the change management that's needed to effect real change. This gentleman may be known to some or many of you. This guy is called Jon Hoeksma, who's an emeritus professor from the Harvard Business School, and he's basically the world guru on change management. He's made a fortune out of his publications. And what I thought for a bit of fun is to map through our journey and link different points with some of the key items that Jon Hoeksma believes is important to change management. His research was not done on healthcare, it was done in industry, but he came out with 8 principles around which you either leverage change or you stifle change. So this is where I come from. I got up at 4:45 this morning to come down on the train from the northwest. We have quite a large semi-rural population, and to go from there in Barrow around the road to Lancaster takes about an hour and a quarter. So that's our patch. We've got over 300,000 patients, virtually all registered with GPs. It's a pretty stable population. We've got 3 main hospitals, 2 of which provide acute care, and we get our population swelled by Lake District visitors in the summer. So we've had a long-standing view to developing a single patient record, which and the nucleus of that view arose in around 92-93 when our head of health informatics, now our current CCIO, came from the defence industry, had a look around and said, we need an electronic patient record. It did, however, require a generational change in consultants for that idea to gain traction. So in the mid and later 1990s, we had a whole cohort of consultant staff that were replaced, and then the idea grew with significant numbers of consultants that were needed electronic records. We've been fortunate to have good traction involvement and leadership from 3 consecutive trust boards actually over the time, and we've always regarded this as an organisational transformation project. It's not an IT project. So this kind of links in with Cotter's 3rd principle, which is that, you know, to make change happen, you need to be able to provide a vision, define a roadmap, set some goals, and such a vision needs to be simple and understandable. It needs to be communicable, and it needs to inspire and motivate. But you need a plan. It's interesting to look at the pressures that both ourselves locally, but also the NHS has faced over that time. And it's these pressures that generate the need for change. So I started in post in 1996. A year later, there was a major change in government. A very quick change in the funding formula took £5 million out of what was an imbalanced health economy at the time. So that was our pressure point 1. That really led to the need to merge 3 local hospitals in one trust. We've all faced the pressures of targets to provide more timely and accessible care for patients in terms of treatments, diagnosis and cancer targets. In 2008 we reduced our acute estate by taking acute medicine out of the smallest Kendal hospital. We were authorised as a foundation trust in October 2010. And then we had a few problems. The next year we were defined as having a very high mortality hospital. Within 12 months we were in breach of terms of authorisation of foundation trust because there were concerns over some of our services. And we're now in a position where we've clinically stabilised the trust, Monitor are happy with our plans, but we have a major ongoing local strategy in harness with both our local CCGs, Cumbria and Lancaster, to define a path forward to safe and financially sustainable services. That pathway is come better care together. So here's his first principle: in order to generate change, you need a sense of urgency. And companies and people fail by about 50% to understand how hard it is to make people change. It's far too easy to overestimate success, and it's so easy in a long game to lack the patience that we need to make things happen. So we went live with first of type EPR in June 2010. We went live with Lorenzo, and it had all the usual functionality that you'd expect with an electronic record system. We had CLIN docs with forms, notes and letters. We had the PAS functionality, which managed our outpatients, provided access planning or waiting lists of all sorts, and ADTs to admissions, discharges, transfer functions. We had a results library available. We could click through using portal capability to view x-rays from within the EPR to slip straight through. And sequentially we built further capability on that, including discharge prescribing, advanced bed management. Emergency care went live in 2 phases in 2012. I've missed out that we went live with maternity in July of last year, and we've opened out test requesting now in September. Just to orientate yourself, this is a patient view in Lorenzo with a test patient. So the patient name banner is in yellow at the top. If there's any alerts or allergies, they show up in red, just about there. On the right are various tabs which take you to different parts of the record, where there's notes, letters, results, access plans, what have you. It just so happens that we're looking at in the clinical notes area there. I don't know whether that projects well enough, but we've had quite a long historical problem with providing discharge information to GPs, and for many years we provided our GP colleagues with this unintelligible rubbish. What we're now able to do is to provide proper formatted, intelligible letters, which also include structured terms which can either be snow-edited in to the letter, back from the record, or they can be cited through. This capability was so useful that the rise in use was exponential. We're now pushing out 4,000 letters a month. And the point here relating to Cotter's principles is that you need in a long-term game to be able to generate short-term wins and gain traction and gain momentum and be visible about those wins. Here's a report section. That's an external report endoscopy published through into Lorenzo. This slide illustrates the portal capability because you can see this is local software on top of Lorenzo, which shows a GP summary button. It looks like Lorenzo, but it's not. However, clicking through that button, we have GP platforms both south and north on EMIS Web. And we've got a connecting device, and we can click through Lorenzo into a GP summary screen. Really helpful on AMU, ASU, pharmacy, and ED. That's live everywhere. This is just showing an input section where we can input clinical problems like symptoms, diagnoses, comorbidity. It's pretty easy to input that data. There's other data entry for alerts, allergies, procedures, operations, and so on. In terms of the project, the Go Live project itself, it was well run, it was well governanced. We went live in June 2010. Because it was first of type, we had quite a large Go Live team for several weeks, which numbered 120. Our usual team size is 80. 3,000 users introduced to the system overnight. It worked from day one. It was considered a stable platform by November 2010, and it was signed off by our trust board as being fit for purpose in January. And progressively, the system becomes adopted when people are more familiar with the systems, and it becomes accepted. The key thing here is about the Go Live, and it's bridging from one world to the other safely, and it is a big deal at a major system implementation because there are gaps that patients and other things can fall down in. So how is that managed? Go Lives require very good project management, very good governance, very good communications, and really good risk management. And just some summary tips for it. You need to keep it manageable and credible. Business change processes, do it before or leave it till after. Don't do it during the Go Live. You need some break points, so if there's urgent fixes required to software, make sure you do that overnight, make sure you do it at weekends. We went live with care management. Our ED departments went live several years later, but unless you're on a burning platform, there's some merit in maybe deferring an ED deployment to 2 or 3 months after a major care management. Keep the big bang as small as you can. Forward-going data migration, migrate as little as you can, and key in future appointments to make things safer. However, take back as much clinical information as you can, 4 or 6 years, 6 years or whatever, clinical letters and backloads of results. Look for a good day to go live. A bank holiday is a good day. We've got time to do it. If you're looking for a small deployment, go for a Tuesday, don't go for a Friday. Go lives come with this, do they not? Of course they don't. It's all about risk. It's all about risk management. So what I've appreciated over time is that we've kind of gone through a process where this was an informatics-led process. It went through a clinically engaged phase, and now we're clinically led. I was appointed. We've established my post. We've reset our organisation so that we've got clinical directors and nursing midwifery strategy group who can set priorities. And what you need is a team around you, people who can influence things, and people who are in a position to make things happen and make the right decisions and carry an organisation. You can't do it on your own. Clinical engagement needs hearts and minds, hearts and minds, hearts and minds, and lots of really good communications. Look for your small wins, reward your supporters, and then when you're looking to really get things systematic, there are some red line steps that can be helpful. So I won't go through these, but it is helpful to have 1 or 2 things that are useful to really change the state of the organisation. And it's about communicating the vision, getting people to buy in, communications are, the need for them are underestimated at least by a factor of 10. If you don't do it well, it stalls things. You have to do it well, and you really do need leaders who've got to walk the talk. This is a cartoon of our paper-light outpatient transformation programme, and hopefully by June we'll be seeing 80% of patients in outpatient without the traditional paper record. 6 specialties are taken for a 7-week cycle, and their needs are assessed with their clinical leads and colleagues. Whatever tools and processes need to be built and provided are provided. If they need particular results from different systems in, if they need scanning facility for external letters, all that's provided and then signed off. And this is all about gaining momentum, making things stick, changing the attitude and the behaviour within a trust, and particularly for new staff coming in. You know, it's really important to make sure that they are imbued with the new way